987th meeting of the North Carolina Board of Pharmacy. I look forward to one day reviewing the minutes of the first meeting of the Board of Pharmacy.
We're working on that now.
Morning.
Maybe when we have our
Hi, good morning. How are you?
Good. Your background looks much nicer than mine.
Hang on just one second. Jennifer Birch,
Plant
Jen,
factory here in Durham.
Oh, cool.
I'm sorry, breaking
took
in.
care of it,
Okay, thank you very much. Jen, you're being disruptive. All right, go right ahead, Bill.
That's all right. So anyway, welcome everyone. And I'm going to read the ethics statement and then we'll consider the minutes. As soon as I can get to the ethics statement. In accordance with the State Government Ethics Act, it is the duty of every board member to avoid both conflicts of interest and the appearance of conflict. Does any board member have any known conflict of interest or appearance of conflict with respect to any matters coming before the board today? If so, please identify yourself and identify the conflict or maybe the appearance of a conflict. And if there's a conflict, refrain from any participation in that particular matter. Does anyone have any conflicts they would like to report? Very good. Now we'll move to consideration of the July 2021 meeting minutes and the minutes of the August 5, 2021 meeting. Anybody think we ought to consider those separately? Do we have any suggested changes to either set of minutes?
Motion to approve, President Mixon.
Thank you, Mr. Bowman. We have a motion. Is there a second to approve both sets of minutes?
I think Keith's second in there, Bill.
Yeah,
Oh,
second.
I'm still struggling with getting full connectivity. So we got a motion and a second. All in favor, say aye. Andy?
Aye.
Keith?
Aye.
Ashley?
Aye.
Michelle?
Aye.
Wallace?
Aye.
Minutes are approved. Thank you very much. Mr. Campbell, why don't we move to the technician pharmacist ratio request, and if you will take over and
Sure.
present, I'd appreciate it.
Happy to do it. I'll be my part will be very brief. Cornelius Tolliver is online. I think.
Okay, excuse me a second. Did I ask Michelle? Did I ask you if you voted to approve the minutes?
You did, and I did vote yes.
Thank you so much. Sorry, Jay.
Thank you.
No problem. Cornelius Tolliver is with us today, and Cornelius is the pharmacist manager of Adhere RX and is here to present a request for approval of a 5-to-1 technician to pharmacist ratio. And Cornelius has provided a slide deck, and I'll pause for a second. Antoine and Cornelius, or however we need to get that set up to go through it. Antoine, are you gonna show the slide deck?
I am. Just stand by.
Okay. All right. Cornelius, welcome.
Thank you. Appreciate it. How's everybody doing?
Good, thank you. Thank you for presenting.
So we'll just hang on for 1 second, Cornelius, while Antoine brings up that slide deck.
I'm gonna go off camera for just a second. I'll be back.
Well, I thought we had it, Antoine, and
Just coming. Is it presenting for you all?
there we go. So Cornelius, the floor is yours, and take it away.
All right, great. Well, thank you for having me. Definitely appreciate it. So at HeroRx Pharmacy, a little bit about the pharmacy. We're actually a closed door pharmacy located here in Cary, North Carolina, so not too far from the border pharmacy. We actually service around 46 states now throughout the United States, and we deliver via FedEx, USPS, and also US PAC courier service to our patients. Demographics for our patients, we're about 70% Medicare, 30% Medicaid currently. And a little bit about our patients. These are patients that are on multiple medications, have multiple chronic conditions, face financial and socioeconomic determinants. So these are patients that are very challenged. We actually fill 30-day supplies for these patients. So we believe in talking to our patients every 3 weeks. We do a medication reconciliation for our patients just to make sure that they're on board. They understand exactly what's going on. We talk to them about provider changes, if changes occur with these patients or new additions or anything that happens with their medications. And so we really believe in, being in charge of the patient and communicating with the providers as much as we possibly can to make sure that these patients can be taken care of. A little bit about our company's mission. We can go on to the next slide there. So overall, improve health and value-based outcomes with comprehensive pharmacy care. At HeroRx coordinates medication needs for patients, providers, and healthcare facilities to ensure pharmacy and social determinants of care are addressed. At HeroRx provides simple, safe solutions to help the patient take control of their medication routine. Health plans increase member adherence to improve value-based outcomes and lower cost of care. So really, over the last, year and a half, 2 years going into the pandemic now, we really kind of stepped up and really made sure that we're communicating with these patients even more because the threat of COVID, of course, and these patients are already at risk with their current, multiple conditions and chronic conditions, that type of thing. And so we've really stepped up even more to kind of make sure that we're, the overall goal is to save as much, on healthcare as we possibly can. Providers help patients adherence to medication protocols to reduce these hospitalizations. And our overall goal, of course, is just to improve medication adherence and to reduce those hospitalizations and admissions. Home health readmissions with better medication adherence to help keep patients healthy at home. And so that's just driving home that our company's mission really is just to take care of our patients as much as we possibly can because we understand the risk factors that are involved. Just to give you a little bit of statistics about the company, average daily productions here, 1,500 prescriptions daily. That's dispensed, checked, and packaged. And including now we are taking on hero patients as well. We do have some automation within our pharmacy. And so we try to stay, above with, as much technology as we possibly can to help service our patients to the best, ability that we can. So we brought along things such as compliance packaging. So now our patients have the ability to choose between vials, blisters, and pouch packaging. And we all know that, increasing compliance, you can do this by having things such as compliance packaging. Our call center data, we average around 300 calls. So take home message there is that our patients love us and they love talking to us, obviously. Our outbound daily average calls is around 700. And so this is just, the testimony just showing that we are in contact with our patients. We are in contact with providers. We really go above and beyond any normal pharmacy. Average time per call, 7.5 minutes. And so our technicians and our pharmacists are reviewing these medications every 3 weeks with these patients. Before we ship anything, we review all medications with the patients. If there's a time where a patient says they don't need a certain medication that they're supposed to be taking every 30 days, our pharmacist gets involved and they want to know why. And we counsel that patient. And then, if it's a situation where we have to reach out to the provider, we're going to reach out to that provider. So we're just really trying to go above and beyond. So not just medications now, I believe in, not just focusing on adherence for the medications piece, but it's vaccines as well. During the pandemic, we know that pharmacists have played a major role, obviously, in, vaccinations. And this is just not with the flu vaccinations or with COVID vaccinations. This is pneumonia, Zostrix as well. We've really stepped it up across the board, and they're really depending on us to really take control of vaccinations with the amount of pressure that's on other providers throughout there. So currently, we've pretty much given close to 6,000 vaccines this year alone. We just started this program last September. We started with flu vaccines. We did a pretty good program there. We had about 800 that we did, and then we really stepped it up with COVID, of course, to contribute to the pandemic. And we're right around 6,000 now. We are servicing on and off, site clinics. And so we held some clinics here to kind of help, the Wake County area. And then we went off site, and our focus there was really not just surrounding, Wake County and Durham County, but to really get out in the rural areas. And so we focused on areas such as Cumberland County, Harnett County. So where these patients, they need the vaccine, where they just don't have the education, or they just don't have the transportation, or some are homebound. So we actually went into patients' homes that were homebound and gave vaccinations as well. And so we've really just changed our motto from not just prescriptions, but we believe in vaccination adherence as well. And so we're going above and beyond during this pandemic to make sure we're doing all we can. We also open up the door for point of care testing as well. So we're doing COVID testing, flu testing as well. And we also can do RSV as well. If you know about the increase with RSV in North Carolina has been outrageous this year. And so just another way that we're just providing extra services, ancillary services that, providers need because they are just completely worn thin. And so we're really just trying to maximize the use of what we have and really continue to just set the bar very high for pharmacies. The quality assurance program. So AdhereRx uses a combination of automatic and manual programs to provide the highest level of pharmacy services. Personnel that we have include a full-time regulatory compliance manager located at our corporate headquarters in Tennessee, and a full-time compliance technician on site here at the pharmacy. Visits by the regulatory compliance manager occur monthly. Technician and pharmacist performance and accuracy are sampled and evaluated weekly with results informing ongoing training and necessary administrative supports. Our pharmacy control as part of the Parata machines uses Beacon for inventory and prescription services. The pharmacy conducts quarterly meetings. So in our quarterly meetings, we're discussing the USP 800 compliance requirements. Of course, the State Board of Pharmacy Regulations, which we deliver to, over 46 states. So we have to really be on top of that. Revenue and management, of course, making sure that, we are applying by the CMS and Medicaid standards. Information security updates, human resources, high dollar medications, we're looking at those very closely, and OIG compliance information, of course, as well. Our current staffing pharmacy technician right now, we've really actually cut down a lot since last year. And it's really worn us thin, which is why I'm here today, because we've added all these extra services. We currently have 5 full-time pharmacists, 3 PRN pharmacists that work, close to 25, 28 hours, 20 patient care technicians divided up into 10 patient care, 6 inventory, 3 distribution, and 1 vaccine data entry. And so we've been able to do all of the stuff that we've done is still continuing to get out 1,500 prescriptions daily and adding in the vaccinations, point of care testing, getting into the rural areas. We worn thin. It's been a lot of hours. It's been worth it. But we definitely need some help, which is one of the reasons why we're asking for the increase. And so that gives a total now up to date of 5 full-time pharmacists, 25 full-time technicians currently. The rationale for a proposal is increased in clinical outcomes. So we're actually starting diabetes education, medication therapy management. Our patients need this. Collaborative practice agreements with local providers. So we're looking to, we're looking to add in diabetes educators for our patients when, most of our patient base, 60% have diabetes. We're looking to add that in and collaborate with these local providers. We're looking at pharmacogenomic testing as well. Off-site immunization, that's something we want to continue to do as well, continue to build that. We developed some great relationships with a lot of the employers around. We want to continue to build off those. Looking at LTCs, assisted living, healthcare clinics as well. And so we're looking to partner with those as well, especially now with Booster coming up September 20th. We're looking to partner with a lot of assisted living facilities as well. So I can see that being a big part of what we're doing going forward. Continuing the provider outreach, smoking cessation programs, we're going to be looking at doing that. Of course, continuing the fight against opioids. This kind of fell off a little off the radar, but it's still there, and it's still a niche that we need to make sure that we're attacking on a daily basis. The point of care testing, transitions of care. So a lot of our patients, they're elderly, they're in and out of hospitals. That communication with the provider has to be there. We want to be able to do that. Precepting. So of course, we're looking to partner with Wait Tech. We've already partnered with Wait Tech, and we're looking to, also partner with the pharmacy school. So Campbell, of course, we have students coming from there, UNC as well, and also most recently UNC Pembroke. We're going to be working with nurses from there. And so increasing patient enrollment is going to come as well. And so the prescription services, all the ancillary services that we're doing, we're still going to be increasing our prescription services as well. We talked about the hero patients, compliance packaging. We're looking to hopefully take most of our patients, at least 70% over to compliance packaging to increase that adherence rate. And then of course, just looking to get more payer contracts so that we can service the patients the best way we know how. Just a little quick look at our beautiful pharmacy. Here, welcome to Here RX. You can see the entrance there. This is the area that we use for vaccines. So you can see each cubicle has J&J, Pfizer, Moderna. And so we were able to have all three of the vaccines and really service patients very efficiently in that setup. This is a look at our call center. So it's a very big building, of course. And so here throughout, we'll have our technicians and we'll have our pharmacists sitting throughout, and then of course our leadership as well. And so this is the area where our technicians are taking those phone calls and making phone calls outbound as well. The dispensing area, you can kind of see here some of the setup there. If you go down, I'll show you some of the automation in the dispensing area. You can see here the two Parata Maxes that are controlled by Beacon for inventory purposes. And that's the compliance packaging ATP Duo machine. So that's the machine that actually does strip packaging for us in blister pouch packaging and strip packaging options. So our patients have the options for vials, pouches, or blister packs. And this is the shipping area. And so this is where everything is packaged up after it goes through dispensing, and then it goes out through FedEx USPS or US Pack. Here are some cubicle areas we have set in the very back. So this is adjacent to the call center area that you saw. This is where students will be able to work on projects and things of that nature. So that's kind of like a little student area there. Yep. And so you can kind of see the big thing, I think the take home message here is that, at 4 to 1, we were predominantly concentrating on prescription services. Now we've really expanded a lot with the vaccinations, the point of care testing, the diabetes education. We're really focusing on, being a well-rounded pharmacy, not just focusing on prescriptions, continuing to do that as our core, but really, getting more involved with ancillary services as well is why we're asking for that 1 to 5 increase. Any questions?
Cornelius, this is Ashley. That was a great presentation, so thank you for that. You run an amazing operation. 2 questions for you. First of all, is your pharmacy technicians, are they licensed or are they trained to give vaccinations?
Yep, absolutely. I have 3 that actually took that course, and so we actually utilize that as well, and we're looking to increase that even more. That's one of the drives, is really just trying to, give our technicians a chance for growth. And so I was actually happy to see that, that opportunity come up in North Carolina where they can actually vaccinate as well. And so we do actually have 3 that can vaccinate, and they are utilized for that as well.
Great. And the second question I have for you, as far as percentage-wise, how many phone calls, because obviously you do a lot of med adherence talking to your patients, which is great. What percentage would you say that your pharmacy technicians make those phone calls? Like how much of those calls are they responsible for?
I would say they are responsible for, to our patients directly,
yes,
80%.
Okay.
Yeah, 80%. We really try to give our pharmacists opportunity for counseling, talking to providers. So I would say you can flip side that with the provider side, where it's 90% of the pharmacist calls are to providers. And so we definitely try to maximize our technicians
awesome
as we can.
Thank you for that.
Cornelius, this is Keith. Yeah, I agree with Ashley. It's a great presentation. And to kind of piggyback on one of her questions, so just to make sure I'm hearing you correctly, the main reason that you need this, you're requesting this ratio increase is not so much for production, because a lot of your automation is handling that, but it's more for providing some, these high touch services. Which is a little bit more unique than your standard retail pharmacy.
I think both, but we're expecting a lot of growth from the prescription side as well. And so now that we become a lot more well-rounded, we can see a lot of growth coming for the prescription side as well. But that is correct, Keith. With what we're doing off-site, really concentrating on that rural area and getting into those areas where the patients need us the most, not just for prescription services, but for things like vaccinations and things like point of care testing and diabetes education. We'll definitely need that increase right away. So, yep, that's true.
Cornelius, this is Bill Mixon. What is a hero patient?
Hero patient is, I don't know if you've seen the actual hero machines. So hero patients actually utilize a machine that actually dispenses their medications out to them automatically at a certain time. It's a very unique setup. I have to send you guys some information on that so you can actually see it. But it's an automatic machine. We actually just package their medications and send it to them, and then they're responsible for actually putting it in their actual machine. And then, it's already set and programmed for the time of day. So if you take, hydrochlorothiazide at 8:00 a.m., it actually dispenses it out almost like a bubblegum machine, like you put a quarter in, it just dispenses it out, and then the patient can actually grab it. It's an amazing, amazing machine. So we don't dispense the machine, we just dispense the medications that go into the machine for the patient.
Okay. Bubblegum machine, I get it. We need one that'll drop the pill and make it fly into the patient's mouth, don't we?
I'm working on that, actually. I am working on it.
Bill, it's Jay. I just want to say I've seen those here. It is a pretty slick compliance tool.
Okay. Yeah. Tell me about your quality assurance program. How does that work?
Yeah, so we have a regulatory compliance officer that is really, there for anything that we bring forward. So with vaccinations, this type of thing, he's there legally to make sure that, we're following the protocol that we need to follow. We have the perfect documentation. We have the right setup. He's there also looking at our high dollar cost items as well, making sure that, insulin day supplies are billed correctly. We have the right setup, and we're doing the right documentation for all our audits going forward. And so he's that guy that just makes sure that legally we are lined up with what CMS Medicaid is looking for whenever we have audits. And Board of Pharmacies, of course. So we had one from you, I think, not too long ago for this meeting, actually. And so he's that guy that just keeps all our ducks in a row, just making sure that, we're aligned properly for prescription services.
Well, that
and
makes it like your quality assurance program is one individual.
Well, it's multiple individuals. So we have he's actually located in Tennessee, Franklin, Tennessee, at Here Health headquarters. But here on site, I have a compliance technician who works directly with him and I to make sure that we're aligned. And so it's nice having her on site as well to help with things like audits and submitting these to the payers, that type of thing. And so it's definitely, I think it's multiple people that contribute to it. But it's just nice having him from a legal standpoint to go to as well to make sure that, we're following proper procedures for everything that we do.
How much compounding do you do?
Very little compounding. Magic mouthwash, very, very small percentage, less than 1% compounding.
Well,
yeah,
1% out of 1,500 scripts a day could be 15 scripts. So.
Well, it's about, I would say, if you want to go as 0.5%, like it's really small. So we just don't do a lot of compounding. Mostly just your legend prescriptions, but most of our patients ideally on an average are on 7 medications, 7 to 10 medications, and so that's the kind of complex type of patient that we have here.
If you have a patient that needs a liquid formulation, can you or do you compound that?
Yeah, we can. Yes, sir, we can. Yep.
Do you have a book of compounding formulas?
We do. Yes, sir. Yep, it's located in our dispensing area. Yep.
Do you do audits of not financial or insurance audits, but do you do quality or performance improvement audits?
Yes,
Retrospective audits where you're looking for opportunities to improve?
absolutely. Absolutely. So we believe in that. Yeah, so we believe in doing that. So we basically give out metrics on a weekly basis to our pharmacists and technicians. It's based around, their performance in the software that we use for prescription services and also our call center touch point service. And so we're giving feedback, whether that's call monitoring, it could be, errors, of course, through the software, if it's, typing data entry errors or anything of that nature. And so we do performance evaluations on a quarterly basis as well for each of our employees. And we try to give that, positive and, constructive feedback as well. And so we believe in really just trying to maximize the ability of all of our employees. And that is cross-training as well. And so just because we have a technician that works in dispensing, they are also equipped to step out and work outside in the call center as well. And same thing with our pharmacists. We have pharmacists that work in dispensing that check, prescriptions there after they've been, filled in the vials and compliance packaging, but they are just as equipped to go outside of that dispensing area and work on the phone and make, provider calls and counseling calls for patients as well. And so we believe in cross-training and making sure our employees can do everything.
Let's say I'm a patient and I call in and say, I think I got the wrong medication. What's the process?
So the process there is, okay, we definitely take down the information. And so if it's a technician, we have what we call a patient escalation form, okay? They fill that out with the patient's information, prescription number, and a pharmacist is always checking that patient escalation form. A pharmacist then will reach out to this patient and gather more information. And then let's say if it is the medication is wrong, we'll arrange for a courier service or FedEx or USPS if the patient chooses to come back and pick up that medication and bring it back to the pharmacy. The provider then is notified, if the patient took the medication and if they send the medication, the provider is actually notified as well. That is documented properly into our New Leaf software, which is what we use for prescription services, into that patient's profile as well. And let's say if it is a prescription that's typed wrong, that prescription then will be discontinued so that it cannot be filled again. And only pharmacists have the ability to discontinue a medication. So a technician cannot do that. So that'll be that pharmacist that went inside that patient escalation form and followed through all the way to the very end with that patient.
So at what point do you look into the root cause of that error? And how do you report that error to the rest of the staff so they can learn from it? And how frequently does that occur?
We look at those on a weekly basis. And so what would happen then is someone like myself, or if it's technician, it'll be the lead technician that will go in and evaluate who filled that prescription, who typed the prescription as well. And then that will be notated and it will be shown in the metrics as an error. And so that is calculated by analytics, based on what type of error it is, it will pretty much show in the analytics as a certain percent. And then that actual technician or the actual pharmacist will be, brought into a meeting or a small meeting and talked to and given a chance to, explain what happened. If it's something that I think that could reoccur again, we're going to communicate it to the entire team, of course, try to prevent it from occurring again. But definitely we're going to, make sure that we communicate with that individual to find out exactly what happened so we can try to prevent that from occurring again.
Cornelius, great presentation. Everybody that's asked questions has already asked the questions that I would ask, but we get a lot of these requests, and I do want to give you kudos for a great presentation, having command of the topic and being able to answer the questions on your feet. That doesn't always happen. So thank you for that today. It makes our job a lot easier. Thank you.
You're welcome. Thank you.
Bill, would we be able to go into closed session to make a decision on this?
We certainly.
Ashley, it's Jay. That's what I would suggest is at such time as you all have had asked your questions and Cornelius has had a chance to respond to those, I would recommend sticking because we're online here today, to stick to the process and take it under advisement, and then go into closed session. When we have to go into closed session at the end of the meeting, you can discuss it there, and then I can communicate with Cornelius afterward on that.
Well, let's make sure that everybody's had a chance to ask all the questions they want to ask.
I think whatever I would ask has been covered, I think.
I'm trying to determine if I missed the answer to this question, what is in place, Cornelius, to increase this number and to make sure that, I guess what I'm asking is what's in place to make sure that we have gone from 4 to 5 and the ability to manage that in that space? Does that make sense?
Okay, see.
So what I'm asking is you're going from 4 to 5 and the rule is 4. So what do you have in place going from 4 to 5 to make sure that you can handle the 4 to 5, going from 4 to 5?
Well, if I'm understanding your question correctly, well, we have our current leadership in place, of course. So we have me as pharmacy manager. We have a dispensing manager as well. We have a technician lead as well. Those people are going to make sure that, we have the best training for each of these. Let's say if it's a new technician that comes on, that technician is going to be able to be cross-trained, not just by the call center technician supervisor, but also by the dispensing supervisor as well. So cross-training the employees to the fullest, managing them, giving them constant feedback, making sure that we have the best training up front for them as well. And then allowing them to, of course, give us feedback as well. I think we put a lot of emphasis into training for our employees. So when they come on, they are given, the best training electronically up front, and then they're given the best training hands-on as well. And they'll sit with, one of our best technicians. They'll go through phone calls. We have a testing software site that they'll be on to make sure that they're equipped to use the software properly. And we're really focusing on bringing in the best people that are, can be cross-trained and are willing to do multiple tasks. So I think the key, and one of the things that we really focus on, is just really making sure that we don't have these technicians or pharmacists that are predominantly one skill in one area. We want them really to be able to do multiple things and think outside the box, whether that's being a pharmacist that, wants to give vaccinations. We also need that pharmacist to be able to check prescriptions and dispense prescriptions as well. So we're looking for well-rounded individuals. So making sure that we maximize what we have, which is what we've done first. And then going forward from there, making sure the new people that we bring in, they're just as equipped to be able to do the same thing, and they want to do the same thing. So getting the right people who want to be well-rounded, I think is really what I've been trying to focus on for our pharmacy.
Very good. Any other discussion?
No
questions?
I just want to point out to all the board members, Crystal and her staff have appended an inspection history. And as you'll see, the inspections of Adhere Pharmacy have been extremely good.
Cornelius, I just want to congratulate
Cornelius,
you.
let me.
Go ahead, Wallace.
Okay. Cornelius, let me just ask one real quick question. Do you have any type of process in place that, you're constantly like monitoring your other pharmacists to make sure that they feel comfortable in, this kind of relationship of adding more technicians that they, have to supervise or oversee?
Well, yes, we do. One of the things that we've done here recently is we've allowed to have a lead supervisor for technicians, and that same person is also the lead supervisor over the pharmacists as well, along with myself. I think, I wouldn't say it's more of a process. I think constant communication is one of the things that, we try to do, and getting constant feedback as well from our pharmacists, and not just the pharmacists, the technicians as well, allowing them to work in small groups. And so within our call center, we have kind of set up like pods where we'll have one pharmacist surrounded by, with the 6 feet, of course, the technicians, and then they're able to kind of feed off of each other's energy. So that working them together instead of putting them, in silos, I think has been one of the things and one of the best changes that we've made. So just putting them in little pod areas is one of the processes that we've added, and it's really worked like a champion. We did the same thing when everyone was remote, where, within our teams, we had actual little pod teams, allow them to name each other a certain name. And it was great because it actually embraced our pharmacists to take more of a leadership role, which is what I want them to do, and more of a command role. Whereas before it was more divided to where, it was technicians here. We see it all the time in pharmacy, technicians here, and then it's the pharmacists. Well, here, no, everybody's working together. Everybody's working as a team. We're going to have constant communication, definitely on a daily, weekly basis. And so I think that's one of the things that has really helped us, Wallace, is really working with the pods and then embracing and allowing our pharmacists to really, really work closely with the technicians and not be afraid to, hey, you made this error, or, that type of thing. And then they give the feedback to myself, and then we can give the feedback, to the team as a whole. And then, we've had surveys. We do surveys as well with our team, tiny poll surveys, where we'll get their feedback on certain topics as well. So just staying in constant communication is the key. And that's been huge for us, especially getting through this pandemic where we have people remote and we still have some that are remote. Communication is just how you solve that issue.
All right, thank you.
Thanks, Wallace.
Any other questions? Cornelius, thank you.
Thank
your
you.
Presentation. I'm proud of your practice.
Thank you. Thank you. I love it. Definitely a dream job for sure.
And we're going to take your request under advisement, and we will let you know what we decide.
I appreciate it, guys. Thank you so much.
Cornelius, I'll reach out to you as soon as the board's made a decision. So
Okay.
I'll give you a call.
Sounds good. I
All
appreciate
right.
it. Thank you so
Yeah,
much.
good to see you. Yeah, good
You
to see
too.
you, Cornelius. Thank you.
You too. Thanks, guys. Y'all be safe.
All right, Mr. President, I prepared to move into the rulemaking updates if you like, or if y'all need a break.
If you would, please let me know too if I have any more, or if you have any more issues with my connectivity or audio or video. Not that
Coming
there's
in
nothing to do about it.
You're coming in 5 by 5 on the
I guess
audio,
I could
Bill.
pedal faster, but my little home generator.
Moving into the rulemaking, then first an update, and Clint will backstop me on things, of course, on this. First is just to let everyone know that our temporary rule governing administration of long-acting injectables has now cleared the RRC, and so it is effective. And as you know, the long-acting injectable authority comes into effect in 2 weeks on October 1st. I think y'all know that my usual practice, and it will be my practice here, to provide, to create and promulgate an FAQ document for pharmacists, which I will do between now and October 1st. I've just been exceptionally underwater, even my usual deep dive standard here, so I just haven't gotten to that yet, but I will. Clint's got his hand up, so I'm going to make sure I don't go too far off the path here. And you're muted, Clint.
Yes, I'm fact checking, Jay. The RRC has not quite approved the rule. The meeting is Thursday.
That's right.
The council have given me some changes that we tweaked, nothing substantive, and I do not anticipate that anybody will raise any objection on Thursday.
That's right, Clint, thanks. I forgot about that, obviously, we had to move that because it's a temporary rule. I think I know Penny Shelton is here, and I know she's going to talk about H96 too, but I think y'all know that one of the requirements, of course, for long-acting injectable is that pharmacists get the appropriate training to be able to administer those, and the rule gives a lot of options. But Penny, I know that NCAP had been working on that as well.
Yes, we have, Jay. First, I just want to thank your board. The whole rulemaking process, I know is not an easy process, and so I want to thank you for your work. I'm sure you don't often get a lot of thanks for what you do behind the scenes, but sort of having a bird's eye view into that process, I know it's difficult, and so just want you to know how much we appreciate what you do. And Jay, if I could, I'll just share a little bit with your board and those listening in what we have in progress, if that's okay.
Sure, absolutely. Thanks, Penny.
So the long-acting injectable legislation obviously was a very important initiative for the North Carolina Association of Pharmacists, and we've been hard at work since its passage as part of the COVID relief bill, and particularly over the summer, we've been working with a team to develop education, training, and a toolkit of resources for pharmacists related to this new authority. These efforts have been coordinated by Cheryl Viracola, who's our Director of Practice Advancement here at NCAP. And we've been working with a team of NCAP members, notably Vera Reinstein, Jerry McKee, and Andrew Bloom, who all three have been instrumental in helping us to develop our content. And the content that we are working with, it'll be comprised of a number of recordings, demonstration videos, and supportive documents. Essentially, we are anticipating three key parts in order for pharmacists to be able to legally administer long-acting injectables. So that training piece that Jay mentioned that pharmacists would need to complete. We're anticipating three parts to that. The first part being devoted to medications for behavioral health, long-acting injectables. And we also want to include a small component to that learning module on stigma. And then we have a part two that will be devoted to the most common outpatient, non-behavioral health, long-acting medications. And then the third part of that for what will be legally required for pharmacists to be able to administer includes administration techniques. Notably, we want to spend some time on Z-track administration. We also want to include some things around best practices. So, adequate staffing, private consultation and administration areas, and then, of course, the requirements that are spelled out in the statute as well as the rules. Another component to that we want to include is the communication template, because there's a communication back to the primary care provider or to the psychiatrist with regards to this body of work. There's another component that we do want to include. It's obviously not going to be a requirement, but would be optional, and it would be for essentially sort of thinking about this as what would pharmacists need or be interested in having that would allow them to optimally practice this new authority. And so we're including some things around marketing and communication with physicians in the community. We're also including some information about how to partner with LMEs and MCOs, sort of a team connect, how to get connected and how to become recognized as a provider of long-acting injectables for behavioral health purposes, as well as some viable business strategies, which will include some information around billing and some different types of ways to implement, such as partnering with a nurse in your practice. So those are really what I wanted to share, just so that people are aware that it's in development. We do plan to, we're going into the recording phase right now. We're going to be recording it in a way that it will be packaged in small bite size so that pharmacists can kind of move through the modules and can digest the information as they go. So we'll be putting out information very soon about how to get access to these training materials. And Jay, that's all that I really had on long-acting injectables, unless your board has questions.
Penny, I just want to say thank you. That all sounds great. I mean, this is kind of a tad bit overwhelming, and that right there, what you just summarized about the training, makes me feel like that when I get that I'll be ready to go. So thank you for very thorough, big picture there on that. So that sounds great.
You're welcome, Ashley.
Penny, I have a comment. It sounds to me like there might need to be a competency component where somebody actually goes in front of a trained healthcare provider like a nurse and demonstrates they know how to do a Z-track injection or a deep IM injection. Have you guys talked about that? Is that being considered?
Bill, I'll have to say that I'm not the individual on our staff that's actually coordinating. I know that they have talked about sort of demonstrating or in-person sort of administration technique versus with regards to can pharmacists actually pick up the technique, given that we're talking about certified immunizers. So really it's a shift in the administration technique to some degree by learning about Z-track administration for gluteal injections specifically. And my thinking on that is that there are a number of videos that clearly demonstrate how to do the injection appropriately. We have talked about, do we want to have in person versus the ability for pharmacists to be able to just take this information and glean it from video technique. I think that there's actually been some other healthcare professionals that have sort of taught this technique by video, but again, I'm not the coordinating person on our staff. If your board would be interested in having more conversation around that, we'd be happy to connect with you on it.
Okay, I'm not trying to throw up roadblocks. I just was, it seems to me like training is one thing, competency assessment is another part of it that should be considered. And I also want to mention that it's possible that we can team up with local health departments to help pharmacists get a quick competency assessment if it's deemed that that's really going to be required.
And Bill, if I'm correct in that, Jay, you may want to clarify, that is an option for us. We don't have to go through this training course. That is an option. And so people can, I've already done that training. Now hearing Penny talk about this, I think I'm going to do both, but certainly I think that's a great option for a lot of folks that are already in the field and are ready to get their, feet down on this. So, and I think for me, that was great because I got to spend an hour with an RN and she did a lot of training for me that I felt more confident about it.
Ashley, you are correct that the temporary rule, paragraph C is in Cat 2, which lists the options for obtaining training. Those options include state or local health department programs or training by qualified practitioners. So those you're right, Ashley, those are options.
What sort of documentation would need to accompany that kind of training, Jay?
We very studiously avoided getting highly granular about that in the rule. I think having documentation in terms of a letter or a notation from the person you trained with would be fine. I'm sure NCAP's going to have a certificate and they track their course attendance and the like, but as long as any pharmacist has some record in which a practitioner or a health department, for example, indicated that they'd gone through that training, that would be fine.
Can I ask another question about this? Let's say Keith wanted to administer long-acting injectables in his pharmacy, but let's say his wife's a nurse and she works there part-time, or he wants to hire a part-time nurse. Is that nurse working out of that pharmacy working under the Pharmacy Practice Act or the Nurse Practice Act? And does it matter?
Well, historically, the answer in the bad old days before pharmacists could really administer any sort of injectable, pharmacies very commonly hired nursing staff to come in and be at their pharmacy and do that. And board staff advice always was, as long as what the nurse is carrying out is consistent with the Nursing Practice Act, they are welcome to do that. They have an independent authority to do that.
Okay. Any other questions on the long-acting injectable rule? Penny, thank you for your information. I don't mean to cut you off, but there may be other questions.
No, that's fine, Bill. Thank you. And Cheryl popped into my office. She was listening in, and so the team is actually discussing in-person training, which would include obviously more of a competency assessment piece for those that would feel more comfortable getting training in person versus online.
And I have communicated with the schools of pharmacy about this too, to point out to them that there are opportunities available for developing training. So sounds like folks are working on it as they should.
Very good. And there's no other action we need to take on that today, correct?
I obviously Clint caught me on getting the cart before the horse on the RRC review, but we'll have an update for you guys right after the RRC meeting. And Clint, that meeting is next week, is that right?
This week.
This week.
You don't know
Thursday.
the universal symbol for this week?
No, I did not. So it's Thursday, right, Clint? I'm guessing that was a yes. Very good. So that's it for that one, Bill. So if there are no further questions or comments, we can move on to the limited service permit rule.
Okay, please do.
So board members, as you know, at the July meeting, we had a public hearing on two rules, one of which was adoption of a new rule governing limited service permits with some conforming amendments to a handful of other rules. And the board received a handful of written comments. The board did not receive any verbal comments on the limited service permit rule at the public hearing. At the conclusion of the meeting, of course, each of you received from me a memo which detailed each of the comments that had been provided in writing and some staff response to that. And the limited service permit committee met on August 19th to review all of those comments. And at the conclusion of the committee's review and discussion, the committee voted to recommend to the full board that it adopt the rule as proposed with two non-substantive changes to the wording in the rule. And if you scroll down through your materials, you will see, I'm going to give you the exact page numbers in just one moment here. I'm telling you, I think my poor laptop labors to scroll through documents when I've got Teams open on this. But there are two non-substantive changes that the committee recommends. One is a change, we're really in addition to the definition of healthcare facility, to clarify that assisted living facilities and ambulatory surgical centers are within the definition of a healthcare facility. And then the second recommended change was a slight amendment to the introductory clause of paragraph A of new rule 1616. And that was to make clear that the rule says here are pharmacies that are eligible to apply for a limited service permit. It doesn't mandate that they only be a limited service permit. So with those two non-substantive changes to the rule, the committee's recommendation was that the full board vote to adopt the rule and move it into the rules review commission process. And I will stop there for questions and comments.
Any questions? believe we need to vote if there aren't any. I believe we need to
I
vote.
would just say that a lot of discussion went into all of it.
Go ahead, Wallace.
I would just say that a lot of discussion went into this. We did a dive on these things several times, and and I think we have been able to hammer out a pretty good document, so pretty good proposal.
Yeah. Thanks, Wallace. Well, if there's no other discussion or questions on this, we would like, or I would entertain a motion to either approve moving forward.
I think the law was going to speak about something.
I was just going to say that unless there is a train wreck that is unforeseen, the effective date of this will be November 1st, so it will be applicable perfectly to everybody who renews for next year.
Okay. Do we have a motion to approve?
I'll make the motion.
Second.
I'll second, Bill.
Keith and Ashley, thank you. We got motion and a second. Any further discussion? Vote to approve or not. Andy?
Aye.
Keith?
Aye.
Ashley?
Aye.
Seems redundant since you both made the motion. Wallace?
Aye.
Okay. Michelle?
Aye.
And I also will vote to approve it. So there you have it, Mr. Campbell. You all can go forward.
Very appreciative. And of course, I would be remiss if I didn't mention again that Crystal Brashears and Chase Bissell really pulled the laboring oar from the staff side on gathering data and presenting it to the committee. So thanks to both of them for their hard and good work. And Wallace and Bill, really appreciate the very thoughtful discussion and comments you had throughout the process. I think it tremendously improved the final product.
You're very welcome.
I'm showing 11 o'clock. What's the will of the board? Do you want to keep going, or you guys need a biological break? What's your pleasure?
It's probably a good point. Let's take I show 10:57. Why don't we try to resume at 11:05?
Sounds good.
And
thanks, y'all.
Temporarily adjourned.
We will be right back. Clay and I apologize about getting that RRC thing bollocksed up. That had just, it's not like you hadn't emailed me a half dozen times on it.
That's okay.
.11:06. I'm sorry I'm late. I was eating peanut butter and I had to get it unstuck from the roof of my mouth. Shall we resume?
Let's see. It looks like I'm sort of looking around. Looks like well, there's Michelle, and we may need to give Wallace just a second.
I don't have video for Wallace. Is that?
Well, he's it's up, but it's the blurred background.
I don't have Michelle on video either.
She's in the room. Right there she is.
Here she is.
Well, Bill, Chair's prerogative. If we can wait another minute or go ahead and proceed as you wish.
Let's go ahead and Jay, if you'll please present the latest on the FDA MOU.
Indeed, happy to do it. So, board members, I know this is probably the 5th or 6th time you've seen the memo, and I've just added on the latest on this. So, as you all know, the board has already decided that it is going to enter into the MOU with the FDA. And the only thing we were waiting to get done before doing that was completion of the rulemaking amendment to Rule 2801, which would require pharmacies to report information required, compounding information required by that MOU into the NABP information sharing network. That rulemaking is complete, and so that there is no authority or system issue standing in the way of signing the MOU. The one development which I'm going to tell you about, but then suggest it ought not to be one that changes our approach, is that the FDA did announce last month that it is extending the deadline for states to sign on to the MOU prior to the at which time the FDA will begin enforcing the 5% interstate compounding distribution limit against pharmacies in those states that have not signed the MOU. That deadline originally was October of 2021. FDA has extended that deadline until October of 2022. I think the primary impetus behind that was there are a number of states that are doing some rulemaking or seeking some legislative authority that they need to be able to sign on to the MOU. We have obviously addressed all of those issues. So the board could, if it wished, not sign the MOU yet and could wait until the October 2022 deadline draws closer. My suggestion and recommendation is that we go ahead and sign the MOU at the appropriate time this fall. And the reasons for that are, one, we don't have any, as I've already said, we don't have any barrier to implementing this thing. Number two, I have confirmed with the FDA that if the board signs onto the MOU this fall, pharmacies will not need to begin tracking their compounding numbers, which I'm sure they're tracking anyway in their own systems, but will not need to begin tracking those until January 1st of 2022. Pharmacies will track their compounding numbers throughout calendar year 2022, and the first obligation they will have to report those numbers will be in early first quarter of 2023, reporting their previous calendar year numbers on that. I feel like that since all the systems are in place, I would like to go ahead and get the MOU signed so that the board staff can go ahead and start educating pharmacies on what the requirements are going to be, how to do those, what to track, et cetera, and we'll give pharmacies all of 2022 to adjust their processes as they need to do, and be completely set and comfortable with by the time that first quarter 2023 rolls around to make those first reports. So that would be my rationale for suggesting that we go ahead and sign the MOU this fall. But I will stop there because y'all may well have questions or comments on that.
I believe the board has already voted to enter into the agreement. So that's really not a question.
That's correct, Bill. I guess the question that really is on the table is whether the board wants to go ahead and specifically authorize me to execute the MOU on its behalf this fall, or whether you would like to wait until next fall.
Plus, we've had opportunity for pharmacists in the state to provide comments, right? So that's
yes. In fact, we had two separate comment periods on that.
Is there any reason at all to wait on executing the document now?
None that I can think of, Wallace. Candidly, it would seem to me like a can kicking exercise just for the sake of kicking the can. Again, the delay, the extra delay, really came at the behest of some other states that are still working to get some rulemaking done or some statutory authority they need to be able to represent that they have that those boards have the authority that the MOU obligates them to have to carry out their obligations under that.
Mr. President, I would make a motion that we go ahead and execute the document.
We have a motion from Wallace. Do we have a second?
I'll second that.
Ashley seconded. Any further discussion?
Just a quick clarification, if I may. And Wallace, would it be the intent of your motion that it authorizes the executive director to sign that MOU at the appropriate time this fall? There's some things I need to get ready to go before I get it signed. I couldn't read your lips, Wallace. You're on mute.
I'm sorry, I hit my
No new taxes.
unmute. Okay, no new taxes. No, those are words you definitely don't say. That's fine, Jay. Whatever the way the motion needs to be recorded I'm fine with it. I think everybody understands that you've got some items you need to take.
Sure.
So
Thank you, Wallace.
Mr. President, I do have a question, just to make sure. So it's really not going to matter when you sign it. The end result's going to be the same. Just to make sure I'm clear on that.
Correct. That's correct.
Okay.
It's just, Keith, that I want it to be the case that as soon as it is executed on our end, that I have everything in place to publish out to pharmacies and pharmacists in the state. So I'm just trying to coordinate a landing of all of those things.
Okay.
But there won't be any substantive. There's no substantive importance to whether it's today or a month from today.
Okay. Thank you.
Any other questions or comments? So we got a motion and a second to proceed with wrapping up to signing it this fall. If you'll indicate your approval or disapproval of the motion. Andy, you approve or disapprove? Aye, I'd say that's approved. Keith?
Aye.
Ashley?
Aye.
Wallace?
Aye.
And Michelle?
Aye.
And I also would agree with going ahead and giving the executive director the thumbs up to proceed.
And
I appreciate that.
And for the record, verbal aye, I'd give you a verbal.
That lays the groundwork for the culmination of a law that was signed November 2013. So 10 years later, the FDA will start being able to gather data that they think they need to further regulate pharmacy compounding. Man, the wheels move slow, don't they?
The wheels of justice turn slowly, but they grind finely on that. Thanks, y'all, for that.
Committee progress.
Next item is monoclonal antibody treatment. I had sent you guys a memo on all the possibilities, and events have overtaken us. As I've communicated with each of you, the United States Department of Health and Human Services has issued a 9th amendment to the PrEP Act declaration concerning the COVID public health emergency. That declaration, as is detailed on the guidance document already on the board's website, authorizes immunizing pharmacists and qualified technicians to order and administer, and qualified techs and interns to administer COVID-19 therapeutics. There are conditions on that. As you all understand, the primary application of that at this moment would be for Regeneron's Region CoV monoclonal antibody product. So I have published an FAQ document on that. Just prior to the USDHHS PrEP Act declaration, Governor Cooper issued Executive Order 232, which authorizes State Health Director Tilson to issue a statewide standing order about expanding monoclonal antibody treatment for COVID-19. So I will be happy to get into as much of the weeds on the declaration as you would like. It does set out very clearly what the requirements are. There is an additional training requirement. A qualified pharmacist who's been exercising vaccination authority under PrEP Act declarations will have already received, and any immunizing pharmacist in North Carolina will have already received the hands-on injection training that's required for that. But the PrEP Act declaration here also provides or sets a requirement that pharmacists and technicians also obtain ACPE accredited training on COVID therapeutics, assessment, screening, all the aspects of administering that. I have reached out to both Campbell and UNC, who are ACP accredited providers in North Carolina, and I understand work is underway at both of those schools. And I also want to note that Amanda Fuller Moore is on the call today, and Amanda is, as ever, the single best resource in this state for pharmacy on all of these COVID matters. So Amanda, if you're on and you want to jump in and tell them what I've left out or misstated. I'm hearing nothing, so I can't possibly be that I got it all right. Well, we'll see if Amanda indicates. But board members, questions, comments, what can I illuminate or obfuscate for you?
Jay, you did say that you have created an FAQ on that already.
I have, and I emailed that to y'all. Y'all got a draft, and then I emailed you the final form yesterday, and it is up on the board's website.
Jay, this is Andy. I got your email yesterday, and I know you've been communicating with UNC as well. My perception of this is that this is something from an educational perspective on CE that we needed yesterday. I mean, this is like hot potato, needs to get done very quickly, correctly?
I think that's right, Andy, because all the rest of the authorization under the PrEP Act declaration is self-executing. There's Amanda's coming back on. The rest of it is self-executing. The potential bottleneck is getting that training done. So I've reached out, and Amanda, I see you just joined, or joined back. So wanted to give you an opportunity to, of course, talk about the MAB stuff.
Thanks, Jay, and apologies because I am joining from my phone. But we appreciate any, assistance from any pharmacy interested in providing monoclonals. Happy to work with the ACPE providers in our state to be able to get that training out as soon as possible. We're working with Medicaid to make sure they get information out on billing and reimbursement, but also happy to answer any questions that people might have.
Amanda, can I ask very quickly, and this may be something you and I can talk about offline, but do you want us to set up a process whereby pharmacies can notify you all that they want to become MAB administration sites?
If a pharmacy wants to become a site, they're gonna get, sorry, that's my other meeting in the background. They're gonna, we're gonna be sending out some information because there's a specific process, which literally in the last 5 minutes, we got an email that the process is changing. Okay. And so we'll be able to send that out for how people will get involved to order. If they want to order, we'll make sure that you guys get that, Jay, to be able to send that out.
Got it. And as you know, the instant you give it to me, I'll get it out.
Quick question while we've got Amanda on the phone, and Jay or Amanda, either one, please feel free to jump in. Do we have any idea predictively what the uptake on this is going to be from a standpoint of how many pharmacies or pharmacy operators might jump into the fray here?
I don't, Andy.
I mean, I think a lot of people will be on board with that. I mean, I'm certainly interested. I don't know about Keith, but if we can continue to help people and get this under control, I'm game.
Okay.
And I think a lot of other folks are going to feel that way.
Well, you'll get an amen from this corner.
Okay. If that's an indicator to me from two independent pharmacists that you're going to get involved in it. So that's what I was looking to hear. Okay.
Yeah. I mean, I think especially in the setting of long-term care, you'll see pharmacies get involved as well. We've heard from a few pharmacies in the last couple of days. It's not a simple process. You're talking about COVID positive patients, so you have to have very good mechanisms in place because you obviously don't want those patients just walking into your store. So that is something that has to be considered in the process. The patients also have to sit and wait for an hour in a setting where the pharmacist is immediately available to them. And so they're, this is not somebody walking in, picking up a prescription and walking out, or walking in and getting a vaccine, waiting for 15 minutes even and walking out. So there will be some pieces like that to the puzzle. And there could also, at the federal level, they're also looking at supply and what that's going to mean in terms of what states can order in a week's period.
Amanda, would you be comfortable with me updating what I've already got up on the website to just say essentially pharmacies that are interested in providing this therapy essentially should stand by for further communication from NCDHHS about process and procedure?
Yeah, I think that's fine. Those pharmacies that tend to want things usually reach out to Patrick, and Patrick forwards those to our monoclonal lead.
I will. I tell you what, then, Amanda, if you think it's right, then before I utter anything that makes Patrick's life more difficult than it needs to be, I'll communicate directly with Patrick to make sure he's good with what he wants said on that.
You could just
because he won't be. Yeah, he won't be their contact for monoclonal antibodies. So
okay, all right, I will get that squared up. Give me an excuse to go see the cutest little girl on the face of the earth again.
Amanda, I have a question for you.
Sure.
How many subcutaneous injections will it take to complete a dose? For
4.
4 sub-Q injections of
it's 4.
what volume?
I think it's 4 at 2.5 mLs.
2.5. Okay. Is that a totally different dosage form than the one meant for intravenous administration?
It's the exact same product, mixed
okay.
differently.
And you know what the approximate cost will be per dose or per treatment?
There's no charge for Regeneron or the bamlanivimab product. There is a $2,500 per dose charge for the sotrovimab product. Sotrovimab is not controlled through the federal ordering process. It's commercial market order through, I'm not sure if it's order through the manufacturer or order through your wholesaler, but the sotrovimab monoclonal is not controlled through the federal process.
Okay, thank you.
The reimbursement rate right now is $450 per administration, unless you do it in the home. The in-home administration reimbursement is $750 per administration.
Wow. And that's for sub-Q or IV?
Yes, but the pharmacist PrEP Act declaration limits you to sub-Q.
Wow. Okay. Any other questions for Amanda?
Amanda, thanks for being on here, and I will tell y'all, I appreciate Amanda every single day, but I especially appreciated Amanda when I was drafting the guidance document, because she saved me from making a couple of absolutely boneheaded mistakes. So as always, Amanda, thank you for saving me from myself.
Well, we have great appreciation for the Board of Pharmacy and all that you guys do to work in partnership with us. So.
Thanks, Amanda. I look forward to helping you, working with you guys to communicate and make sure, and I know you'll make sure I communicate the right thing. So.
Awesome. Well, I'm going to hang up, but if you need me, Jay, you can just text me and I'll join back in.
Okay. Thanks, Amanda.
Thank you.
Thank you.
That's all I've got on monoclonal antibody stuff, Mr. President, unless there are other questions or comments.
Sounds like there's a lot more to come.
Yeah, absolutely. And I am impressed, though, that the PrEP Act declaration came together pretty quickly on that.
What do you see would be the earliest date that a pharmacist could administer that monoclonal?
I couldn't give you an intelligent guess on that, Bill, because I don't have a good sense about how fast the training programs are out there. And it sounds like that, as Amanda was discussing, that the pathways for getting sites up and ordered or two. So I'm not sandbagging you, Bill. I just don't have enough information to have an intelligent opinion on that.
Well, there's no limit in the emergency use authorization, I presume. So the choking point for the CE and the supply stream.
Yep.
Also, I saw something about cold storage. Is the cold storage requirement manageable? It's not the ultra cold.
No, it's not ultra cold storage. It's standard freezer temperatures.
Okay. Very good.
I mean, just the education alone, Bill, is going to take, it's going to take a few weeks for us to pull that together, from a CE perspective, just to give you some idea. UNC and Campbell will both work on that, and we're already talking about it as of yesterday. So, I don't know if I can put a timeline on it. I mean, we're going to front burner the thing and do it as quickly as possible given the circumstances, but it'll take some weeks, I think, to get it all pulled together.
I presume that's a more extensive training than administering a long-acting injectable.
Yeah, and it's just, you want to make sure you're checking off all the things that they intend for there to be in the education, and you got to get speakers. You got to figure out, is this going to be a recorded thing? Is it, a live event? It's probably going to be virtual. I think that given what we've got going on with COVID, it's going to have to be virtual. And we'll just, we'll get it done.
I'm sure. And Jane, that will be a standing order?
Well, yeah. So the PrEP Act authorization is a freestanding authority for pharmacists to order and administer that therapeutic. You don't have to have a standing order. Now, Amanda, I hope I don't bollocks this up. Amanda would be probably clearer on that. There is going to be a state standing order. Remember that the importance of the state standing order tends to be sort of twofold. One is it's a Medicaid billing issue, that Medicaid tends not to pay for these sorts of things done by pharmacists unless it's done pursuant to a state standing order. And second, at least where the vaccine stuff, and Keith and Ashley probably forgotten more about this than I'll ever know. The other advantage the state standing order has is that it makes your record keeping easier, because your prescriber is always recorded as Dr. Tilson as the person who issued the standing order.
Yeah, and I'm thinking more of the exclusion criteria and the inclusion criteria and the screening.
Right.
Right. Data that each individual pharmacist should not have to develop on their own.
Right. And if form holds, as I'm sure it will, Dr. Tilson's standing orders always include all of those facets.
Great. Thank you.
Mm-hmm.
And my apologies for trying to skip over the monoclonal discussion.
It's all right.
Committee reports, but
Well, that's a good segue, Bill. We can move right into committee updates, and you have a memo, and certainly any members of the committee that want to jump in, just quick updates. Telepharmacy committee is working very diligently and hard on reviewing all the comments on the RMOE rule. The committee has already met one time. We were scheduled to meet a second time, had to postpone that. But Keith, Andy, and Wallace, I'll be communicating with you guys probably this afternoon to start, so we look at some dates to reschedule. But that committee made substantial progress in the review of the RMOE comments, and recall that its charge is to digest all of those comments and make recommendations to the full board about how to move forward on the RMOE rule. Andy, Wallace, Keith, anything I left out on that, or anything y'all need to add?
No, we're good. We'll just circle back.
No, I don't think so.
Yep. And I like to say, I'll get with you guys later today about some a new meeting date. Permit meeting, pharmacist manager education committee. I think members of that committee, Ashley and Keith, I think, Missy continues to keep that moving ahead. And I think she has scheduled with y'all a date to go through where you are at that next meeting of the committee. Clint will be presenting to you all some draft rules to implement the recommendations that the full board has already approved. Missy and her team continue to work on the educational videos, so all wheels continue to move forward on that one. And it sounds to me like at y'all's next committee meeting, we'll probably get most of this fairly well nailed down. So thanks for that. Keith, Ashley, anything to add? Or Missy?
I appreciate Missy's work on this because she's done the lion's share of it.
She's terrific, that's for sure. Working Conditions Committee, just a reminder that both Keith and Ashley and our very own Ellen Vick have all been appointed to the NABP task force that is meeting in November to explore these issues, and look forward to the committee coming back after that and really digging in to see what of those things we need to implement or change and how to go about doing it. So grateful to you all for stepping up and serving on that task force.
On that topic, would it be appropriate for us to circle that committee back up before they go off to the meeting, maybe an October meeting or something like that of that committee? I'm just thinking aloud here. We're ramping up into that time of year where the circumstances regarding work conditions are going to be enhanced with cold and flu season, flu shots added to COVID, and hospital census is going up in general on top of being up for COVID. I just think we're headed toward the tough time of year, and so I just want to make sure I feel like that we're addressing the issue or working on the issue, if for lack of a better term.
That's entirely up to you. If y'all want to, if the direction of the committee, I'll be happy to work with y'all to get a pre-NABP task force meetup scheduled on that. I'm seeing nods from Keith, nods from Ashley. Okay, Andy, will do. I will get on that.
I'm not on that committee, but I'm happy to.
Oh, I'm sorry, Ashley.
Or do whatever. It doesn't matter. I'm happy.
And I'm sorry, Ashley. I said that because you're going off to the NABP task force. So I think probably you should be a part of any pre-NABP task force meeting on that. So.
Happy to be a part of that.
All right. Thanks, Ashley. And then Pharmacy Intern Registration Committee. That is Andy, Keith, and Michelle. And as you all know, the board has accepted y'all's policy recommendations about creating an intern registration system. Clint is working on draft rules to implement that, and Missy has begun discussions with ThoughtSpan to implement a registration system. And as you all know, we have a deadline to get that system up and operational by August 1st. of 2022. So Keith, Andy, and Michelle, I think what we'll do is when we've got the probably got the proposed rule where we're ready for y'all to take a look at, we'll get I'll get a meeting scheduled of that committee so we can go over that rule, and Missy can give everybody an update on the programming, because never too early to get the rulemaking process started on that so that we can meet our August 1 functionality deadline on that. And those are the committee updates. Clint, anything I left out that's relevant to any of those? He says no. So those are the updates, Mr. President. Obviously, any more questions or comments? I'm wide open.
Well, I'm not hearing any.
Nor am I.
Any other discussion or questions about any of the committees? Thank you for that report.
Thank you to the committees who are doing good policy work here, moving everything forward. Next item then, Bill, is legislative report. Let me clear the underbrush first. I've got, the real topic for discussion is that H96 has now become law. I've given you updates on the other bills that relate specifically to the regulation of the practice of pharmacy. And there hasn't been any movement on any of those others, but H96 has been signed into law, and I know Penny's still on. And Penny, I think I'd like to start out by giving you the floor to take some well-deserved credit for NCAP for the hard and good work, and telling us what's going on and what are the things coming up that we need to be prepared for.
Well, Jay, I appreciate your kind words, and thank you for the opportunity to share some information with your board and those listening in. So as all of you are aware, House Bill 96 was kind of the merging of actually two different bills, our public health bill, which originally started out as Senate Bill 575, and then a bill, House Bill 96, which was an attempt to actually get medication administration into scope. And that got sort of diluted down to self-administered meds and a few other things that are important that were put in around immunizations. But what I wanted to speak to you about today are the provisions that came out of the original 575, which was the public health authorities that will require standing orders. And those include pharmacists the ability to provide glucagon, prenatal vitamins, nicotine replacement therapy, post-exposure prophylaxis for HIV, and oral and transdermal hormonal contraception. Huge wins for our state, and very, very excited for us as a profession moving forward with this with these new authorities. I wanted to tell you that NCAP, since the passing of the bill, NCAP is doing two things. One, we're working on, obviously, education and training, which is kind of our one of the things that the association is always known for, but we're working on that. But we've put together small teams to draft standing orders. We wanted to be proactive to provide Dr. Tilson with drafts that would be effective for pharmacists while ensuring safe practice, sort of thinking of it as being proactive in providing a starting point for DHHS and Dr. Tilson's office. It takes a village. So what we've done is we've pulled together these small teams. The teams have been in place. They've been working on drafts. And I just want to share with you, because there are a number of people involved. I do want to give a shout out and kudos to those individuals. But we have Team Glucagon, so the group that's been working on the Glucagon standing order. It's comprised of a group from UNC Eshelman School of Pharmacy, that was put together by Stephanie Ferreri, and includes Elizabeth Salisbury, Alexis Shook, Jessica Roller, Phil Rogers, and Green Shepherd. We also have Team Women's Health, which is working on the standing orders for both the hormonal contraception piece and and also the prenatal vitamins. And that's being led by Courtney Mossband from Wingate University and Molly Scott and Anna Pfeiffer from UNC Eshelman School of Pharmacy. Team HIV post-exposure prophylaxis is comprised of Katie Trotta, Ashley Eason, and Libby Porteous, all from Campbell University's College of Pharmacy and Health Sciences, along with Megan Witkowski, who is the executive fellow here at NCAP. And then our final team is our nicotine replacement therapy team, which is being led by Pete Koval from Cone Health in Greensboro AHEC and Michelle Chaplin from Wingate University School of Pharmacy. We've put together the teams. They have a deadline of putting together an initial draft before the end of this month, September. Two of these teams have already completed a draft, and that has been brought over to NCAP for our review, and we're currently providing some feedback back to those teams. Those two teams that have put forth an initial draft are the Glucagon and the nicotine replacement therapy teams. And then the other teams are on track for meeting the timeline that's been spelled out for our plan. What we're hoping to do is to, once we've had a chance to review these initial drafts, make sure that we're happy with them, we're going to then share them with the Board of Pharmacy and with Amanda Fuller-Moore over at DHHS Public Health, so that we can get their input before then passing along to Dr. Tilson's office. So that's where we are with the standing order work. As I mentioned, we are on track for this month. Very excited about this work. A lot of people involved, but also wanted to let you know that we know that there will be pharmacists seeking additional education and tools and whatnot that are going to be related to these authorities. And so we also have groups that are in place that are working on that information as well. So Jay, that's all that I had for you. Unless your group has questions, I'd be happy to entertain those.
And maybe it's a lot and good work, a lot of good work.
Jay or Bill, I was just wondering, I think, I thank Penny for what she's done here, and it's really outstanding. I do think that we need to expedite the process, and if we're going to get these drafts and review them to give them some feedback, do we need to have a way to try to either have a committee or have a group that somehow can quickly look at these things? It'd probably be quicker than trying to wait for a full board meeting and stuff like that.
Yeah, Wallace, you anticipated the comment I was going to make, and just to step back a little bit on this. And so the authority that Penny just described, the authority for pharmacists to initiate medication therapy for these 4 different indications, that authority becomes effective on February 1st, 2022. And the statute provides a two-step means of implementation. The state health director is authorized to immediately issue standing orders to implement those, and those standing orders will remain in place until the Board of Pharmacy and the medical board jointly approve some permanent protocols for that. So you're right, Wallace. I mean, the time is a ticking for February 1st. Fortunately, we do have a little bit of breathing room on that. But there are several aspects of the statute's implementation. There is rulemaking for technicians, and the rulemaking has to be accomplished jointly among the medical and pharmacy boards. It has to be accomplished for pharmacy technicians to administer under state law, the new to administer vaccines under the new state law. Now, the PrEP Act already gives more authority than the statute does, so we're not going to be on pause waiting for that for techs. but we've got that rulemaking that's going to need to be done. Clint, I think I'm correct that there's also there are ultimately some rulemakings that have to be done jointly concerning a process for approving pharmacists ultimately who are going to exercise this new initiation authority. Isn't that right?
I believe that is correct.
So all of that is to say, Wallace, that I think we've got a dual need here, both to be a sort of a rapid reaction force for Penny's folks and a resource for Dr. Tilson, and also a committee to begin the work with the medical board for the rulemakings and other joint projects we have to do. So from my standpoint, I think it would be a terrific idea to appoint a board committee to, I guess, be the vanguard for this and both to help Penny and her folks out and to sort of begin discussions with the medical board about what we're going to do and how we're going to do it. Now, the needs may change as we go forward with the med board and the like, but I think it would be great to have a committee to begin spearheading this.
So I would like to move forward with appointing a committee, and with 6 seconds of battery left, or 6%, I'm scared that I'm gonna have to take a temporary pause before we get this done, so I can, even though this computer is plugged in, or this laptop, it's dying. This has been one day for challenges. Please bear with me while I sign off this computer and get on a different one.
Bill, do you want us to just take a 5-minute break here while you switch out, and then we'll come back? Okay, that sounds good. Well, why don't we take a break then, and when we see your mug back on video, then we'll know we're going to start back up.
Very good. Thank you.
All right.
Hey, does anybody want to talk about Bill while he's not on here?
Well, it's being recorded, so.
Oh, okay. Okay.
I'm going to go refill my coffee cup, so I will be right back.
Can you get me some too?
Yeah, I'll take one, Jay.
Okay, am I back on?
Yes, you are, Bill.
Okay, good. Thank you. It's been a day from technology, where today. All righty, Ashley's back, Jay's back. Jay's muted, Ashley's muted. Am I muted? Well. Okay, so I think the challenge was to appoint a subcommittee of 2 board members to work with NCAP on implementing the new rule for State Law 2020-110, formerly House Bill H96. So do I have, first of all, I'd like to know if there are any board members who have a burning desire to be one of two on this subcommittee.
Burning desire here, Bill.
Okay, there's one burning desire. I need one more burning desire.
If you get no burning desire, I can try to help, I guess,
Okay.
if it's appropriate.
Well, Keith, you're obviously a good candidate. Have you got the time? You're kind of subcommittee.
I got nothing but time.
Oh, Andy, did you? So there's a call for a net being cast for 2 board members to serve with NCAP to help implement this new state law.
I'll be happy to.
Okay, Jay's making motions.
Let him out of the box.
Yes, I started doing the Marcel Marceau thing. Yeah, I think 2 would be the right size right now at the very beginning. I think the need is going to increase going forward, but I think 2 is the right size to work with, to rapidly react to Penny and to also form sort of the advance guard to go over and start figuring out with the med board how we're going to proceed on this. And like I say, I suspect going down the road, we're going to need to add folks or even maybe have different committees, but 2 would be good right now, I think.
I'm happy to serve with Keith, unless someone else mentioned doing it and I didn't hear it before I got up here.
When you were refilling your coffee, Ashley jumped up and down and indicated a very strong desire to be on that committee.
Well, then let it be Ashley and Keith. That's fine with me.
And Michelle, we will consider you for future subparts of this. Very good.
Jay,
all right,
Andy
got a subcommittee.
Andy Ellen has his hand up, Jay.
Yeah, Andy. Well, I don't know how to.
Yeah, I'm on if that's a.
Okay. Oh yeah, go ahead. Go ahead.
I just didn't want to jump in, Jay. I apologize while y'all were talking. I would, if the board would so allow, I would very much like to have a representative from our organization on that committee as well, if the board would so be amenable to that.
Well, I think that probably in terms of the committee composition, it's the 2 board members, but certainly the 2 board members of that committee would have are empowered to reach out and to get input and participation by anybody that they wish to do that. So, Andy, shoot me an email to remind me of this.
And Jay, I'll just say, Andy,
so. Thank you, Jay.
Jay, I'll just say, Andy, I'm happy to forward the standing orders to you directly too for your input.
Yeah.
Thank you.
I think there will be lots of input by lots of folks as this thing plays out. But thank you, Andy.
Thank you, Jay.
Yep.
Well, from the board perspective, then I think we've got our subcommittee set up.
Yep. So Ashley and Keith, I'll get in touch with y'all. I got a lot of committees to schedule. I'll get in touch with y'all and Penny, and we'll figure out and Clint certainly here just at the very beginning to sort of make sure we're clear on what our first steps need to be. Penny, anything else for the good of the order here?
No, that's all that I had. Thank you very much for the opportunity to share some information with your board, though.
Thanks for all your hard work.
Yeah, Penny, thank you for leaning in.
Exciting year.
Yep, sure has. Clint, anything that you need to add about this? I know you've been doing some background prep work. Clint says no. All right.
It leads us to our financial report.
That is correct. So JP Brown will take it away. And Tell us
Good
about
morning,
our
everyone.
financial situation. Hey, JP.
Everybody hear me all right? I'll keep this quick. We're only 2 months into the new fiscal year. Everything is looking good in terms of budget for the year to date. We spent 150,000 less than we had anticipated at this point. We've made about 25K more, so we're looking good already. And obviously that has cushion built in, as we always do. Two standout things, I guess, on the income statement: pharmacist reciprocity and technician registrations surprisingly up at this point in the year. That could even out over time. There's just two numbers that stood out on this month's financials. The other thing was a negative balance in one of the expenses, and I think in the memo I had referenced that as just a return of a surprise return of a refund related to a purchase last year. Other than that, everything looks good, and we'll just keep on trucking. I'm happy to delve into the weeds as always if anybody has any questions. Otherwise, I will turn it back over to you, Bill. Thanks.
Yeah. And who's going to present the financial audit?
So let me talk about that. So board members, the field work has been completed for our annual financial audit by our accounting firm, Bernard Robinson. And I think all of y'all know that each year I have to submit on behalf of the board an annual report required by Chapter 93B of the general statutes. And what has to be included in that annual report is the audited financial statement for the previous fiscal year. JP will correct me if I'm wrong. I think the anticipation is that we are going to get the financial audit report early-ish in October. And we don't have a regular meeting in October, so I need to have a mechanism whereby the board can review and accept the audit report in time for me to file the annual report at the end of October. So my request is that the board would vote to delegate to the Budget and Finance Committee the authority to review and accept the board's fiscal audit report when it comes in next month, so I can get it filed with the annual report. Of course, all board members will see it, and we can talk about it. But mechanics wise, it would be helpful to me if we could get the committee authorized to review and accept that report. We do not anticipate any surprises at all in the audits.
Jay,
that's right.
Not to throw a wrench into this, but you mentioned there not being a meeting in October, and I was going to bring up at some point today that we have so many things going on with the board and with legislation and whatever. And if we're going to be back in this virtual format for the future, I personally think it might be to the benefit of the board and what we've got going on to have a meeting in October, whether that be virtual or whether it be at the board office. That's just my opinion. So that would play into your need here as it relates to the audit. So I just throw that out there because you made that comment.
Well, that's y'all's call, of course. But most of what we have going on is committee stuff, and that's what we've got the time set aside for in October, is for the committees to do that work. And we will be convening in early November for the retreat, which I am very hopeful is going to be in person. So that's y'all's call about what you want to do in October. I'm confident that everything we've got going on with the committees, we can get done that way. But y'all's call.
That's a good thing to consider. Thanks, Andy, for bringing it up. So if we had an October meeting, of course, the audit would be part of that discussion, which in my experience from 9 years is almost perfunctory because it's always a clean audit. What else would we, Andy, can turn your mic back on. What else would we discuss potentially? I guess any committee meetings that occurred between now and then. So that's really
Yeah.
5 weeks to work on that.
Yeah, I mean, we've got, I'll be working on things as it relates to training for some things that we have in place, obviously the infusions and so forth. I mean, I'm just speaking out, I don't want to
Yeah.
speak out of turn. I'm just saying, I think we've got a lot going on with the board, and now we're back to virtual meetings, which I could get off on a tangent on that and my opinions of what we ought to be doing with that. But if we're going to go back to virtual meetings, then I'm not in favor of skipping months with board meetings. I think we have too much going on with COVID and with committee meetings to just be pulling together every 60 days.
Well, that's true, but what actions would we need to take? I mean, we can get reports.
Let me, just the only thing I'll say, I mean, again, it's totally y'all's call what you want to do, but the idea of the off months, of course, is that we've set aside that time for the committees. So at the risk of sounding like I'm whinging, I would ask that there be some consideration that if we're going to take away a reserve day for committees, understand both board members and staff, that's going to it is what it is. But but that was the plan with these off months, is that we would use that time for the committees, so we didn't have to do meetings and committees. But again, y'all's call.
Well, it seems to me like staff already has a pretty full plate. And I'm happy to meet and hear and listen. But I'd like to hear from other board members. See what your opinion is. And Andy, I understand and agree that it would be nice to get together, but I want to make sure it's time well used and that it's productive time and it doesn't take away from committee work.
Well, I think,
Keith, what do you think?
Well, I think this month, for obvious reasons, it was best to do what we're doing today. And if you think about it, look how much has changed from the last time we convened until now, when we met in person back in July. So, I mean, it's been a lot. But I agree with Andy that there's a lot going on that we need to make sure as board members we're staying connected to keeping our thumb on the on what's going on, or maintaining the pulse, or whatever you want to call it. But at the same time, we have a lot of committee work as well. So I don't know where you strike the balance. I mean, I think Andy's got a valid point, but also we do have a lot of committee work that we've got to get done. So I'm for whatever is the most productive and make the best use of our time.
If I could add, I mean, I think that if you look at the calendar, our board retreat is really the first week of November. It's at the very beginning. And, I see where you're coming from, Andy. There's a lot of work to be done, but I do think there's a lot of committee work that needs to be done. And so I would say if that means us wearing a mask the entire time that we are in the retreat, I say let's go for it. But I would think that there's a lot to be done in the next 6 weeks. So if we could make that in-person board retreat possible, that's what we need to do, because there's going to be a lot of discussion at that board retreat.
Yeah, and we are, staff is planning the in-person retreat. We haven't, COVID will do what COVID's going to do, but that is the plan, and we're continuing along that plan.
Michelle, what's your thoughts?
I'll reserve them at this time.
Okay, Wallace.
Well, I mean, I'm one that always felt like we needed to try to really give this plan to meet every other month, to have committee meetings every other month, to give it an adequate time to really get a handle on it. But, Andy makes a really good point. I don't disagree with that. And there's, I don't know, there's just, I can only sort of look back on it, comparing it, the connection is not, is not totally because we're meeting every other month versus every month, but the connection is still, I think among the board members and things like that, it's just not, happening as effectively as, what I think that it could be if we could get together. But the times we've met virtually have been, like Keith said, this month we needed to do this, given the situation. And so I know I'm babbling, and but okay. I think we need to really give it time to evaluate it.
Well, let's reserve a decision on this. Let me give Jay time to mull over the yays and nays, and we'll consider those, and we'll make a decision. Does that sound good? You're muted, Jay.
There, am I unmuted now?
Yeah.
I guess what I would say is that if we want to sort of rescind the meeting plan that we've adopted, that sooner the sooner the decision is made, the better, because I was planning for October to use the normal meeting time to schedule as many of these committees as we could, which was the reason we'd set it up that way. So if we're going to go ahead and have a full board meeting in October, I need to know that soonest, because that obviously that changes the entire equation about when there's going to be time available for committees. I will confess I was working on some possible vacation time. So the faster I can get a decision on that, the better, just so I'll know where to start slotting things in. And we also have to work around, let's remember also, we have NABP District 3 at the beginning of October. We have Multigon, which presently is scheduled to overlap with the normal meeting date. So we'll need to think about, does that change folks' Multigon plan? Like Wallace, I think you were planning to go to Multigon, and there may be some others. So there is a lot going on in October. So if you want to have a meeting, I'd say go ahead and make the decision so we can start moving stuff around.
Well, I have personally committed to doing an accreditation survey, or 2 surveys in October, one of which would be the week of the 3rd, or the 3rd week of the month, which that's going to throw.
And our pharmacy manager meeting is already scheduled for that Tuesday, that we would have had a board meeting. I know that Missy's already got that organized. We're meeting that morning at 10 o'clock, just like we would meet, with our regular board meeting. So I know she's already got that scheduled, and everybody's, calendars have been cleared for that. So I did want to point that committee meeting has already been set for that day.
Yeah.
And I have a suggestion. Go ahead, Andy. I'm sorry.
I don't want to throw a monkey wrench into all this. I just wanted to bring the issue up. We don't have to do an October meeting. I was just saying that with all that's going on, it just doesn't seem to line up with now we're switching to every other month. And so, look, if it's not logistically doable, then it's not logistically doable. Maybe there'll be enough of us at the D3 meeting that we can do a roundup and discuss any pressing issues. That's
going to violate the Open Meetings Act.
Yeah, we can't do that. Can't do that. I saw the law jump up back there on the screen.
I saw smoke coming out of his ears. Andy, in deference to your, I understand. There's pluses and minuses on both sides. It sounds to me like the prevailing opinion is we need to just stick with what we've got as far as meetings, and do the best we can to keep. Jay does a great job keeping us appraised of what's going on. And
let me suggest this too, Andy. This might be helpful to get to you. I've got a grid out we know which committees are already scheduled to meet, and I've got to grid out each of those now that need to be scheduled and who's on what committees, and figure out how to interlock those, because obviously most of you are on more than one committee. So let me grid that out this afternoon too, because that's going to help say how many different days are we going to need, or how many can we move into one. And let me get that. If y'all will work with me very quickly in responding to availability for committees, I can get that gridded out pretty quickly. And if we see that that's just not going to get the job done, then we can figure out what we need to do as an alternative. But
can I make a suggestion too? Since we will be meeting, having our retreat in November, would it be possible, Jay, to get on the agenda, maybe reevaluate what our short-term needs are based on our current situation? We got a lot, like we got a lot of decisions to make, and then and combine that with long term. I think every other month with committee work in the off months is probably the best way to go. But we may have some short term, where we need to meet every month just to make sure we're staying on top of things. Does that sound reasonable to y'all?
Yeah, I mean, I'll give y'all
good.
whatever you need on that.
Jay, I have a
I'm good
question.
with
This
you.
thing that you're going to be gridding out, what is it going to include again?
Right. So I've got on my list here, we've got 1, 2, 3, 4 board committees that need to meet in the short term, and there's overlap in some of that membership. So I know the pharmacy manager committee has already been set for October 19th, and we do as many committees as we can fit in on October 19th. But I've just got to figure out, Michelle, what the overlaps of memberships for those committees are, so that I can help get them scheduled in a way that we're not double booking a bunch of you. That's all on that. But
would it be inappropriate for you to provide a list of committees again and who's on those committees?
Yeah,
that would be
I'd be
great.
happy to do that. Yep. Okay. We'll do
Hey,
that.
Michelle, I did notice on the agenda today, it looks like all the committees are there with the names on there, because Keith, when he committed for this other one, I don't know if all of them are there, but I was picking on Keith.
I'll
he's
reset it.
already on 4 committees and he just got added to another one. So I know that helped me today, because I was like, oh gosh, I'm only on one of those committees. I probably need to help out with another one. So.
And I think that's something we might need to look. Yeah, if we might need to look at that, because I don't want to be on ones as the public member that are inappropriate. However, I don't want to not be carrying my weight as a public member as well. So I don't know what that looks like.
Yeah, I'll reset that for everybody today.
Thank you.
Mm-hmm.
And I will say that I do think we need to try as best we can to let this plan work through and just see really how it does work out. We got to give it an ample amount of time to sort of feel out how it works. I don't know what that is, but I think we need to give it some time to see.
Very good.
He agrees too.
Have we laid that to rest then?
Yeah, I know what I need to do, so I'll get that information to y'all. I'll start getting all that together this afternoon and get it out to everyone. Did we get? I got sort of lost, and I'm not sure. Did we ever get a motion to delegate to the Budget and Finance Committee review the authority to review and accept the fiscal?
No, we have not
year audit
accomplished that yet. So you've discussed that. The audit's coming. Jay needs to get approval to proceed with something, annual report or something, and asks that we delegate to the Finance Committee the authority to approve the audited financial report or the financial audit. That doesn't mean that the board members can't or won't have a chance to see it or comment on it or ask questions about it. This is just a procedural thing, and Jay is happy to answer any questions about that at this point. If there are no
And
questions,
that can certainly be done by a telephone call. So that'd be easy.
If we could get a motion to approve or request to delegate the approval of the audit to the finance committee, then
So moved.
that'll grease the wheels.
So moved.
Michelle has made a motion. Is there a second? Ashley seconds. Any discussion? Those in favor of the motion, please indicate by pointing at your eyeball or making some other noise or sound or motion.
You got to do roll call.
Andy?
Yes.
Keith?
Aye.
Ashley?
Aye.
Wallace?
Aye.
Michelle?
Aye.
Motion carries. Thank you.
Thanks, y'all. So, and I know Budget and Finance is Michelle, Ashley, and Keith. Is that right, or Wallace? I see Michelle. Even I can't remember what all the committees are right now. That's why I need to send it back out. But I'll as soon as we got a firm date on when we're going to get the audit report, I'll get in touch with y'all.
That's the one committee I'm not on.
Yeah, that's right, Keith. I think I'm pretty sure it's Wallace as the third member of that. But again, proving Michelle's point here about a reset on the membership. Next up is the inspections and investigations docket report. I have Josh indicated, but I think it may be Crystal who's actually presenting that.
Yep, it's me.
There you go. Take it away, KB.
So the statistics for this month, so far we've got a total of 271 cases. We have 61 AOC charges, 13 diversion, 60 errors and omissions, 3 incident reports, 47 inspection follow-ups, and 77 procedural legal cases so far this year. And total number of surrenders is 17. We have 1 DME, 4 pharmacists, and 12 pharmacy technicians. And also I wanted to add, as you guys are aware, Chase Bissell left in July. She moved to Florida to be closer to family, and we have hired a new inspector for that position. Her name is Christy Edmondson. She has a background in she was a forensic technician for Fayetteville Police Department, and she also has a pharmacy technician background. She started a couple weeks ago and is in the field training with Holly and Jason this week.
Thank you, KB. And I much credit to Ellen, Josh, Crystal, and the entire department for doing a comprehensive and very effective search for a new staff member. Those guys have really got it down to a terrific process there. So thank you for that.
Very good. Thanks, Crystal.
Absolutely.
Since we've got Crystal, and I'm sorry that I'm springing this on you, but do you have any further or any comments or observations about the recent revision to Chapter 795 or 797?
Obviously, you know, I nerded out and read on the night that they got I'm set to sit in and listen to the one tomorrow for 797. I mean, I personally don't have any complaints of what they issued out with, especially with adding, you know, an additional category for extending beyond use states. It's going to be interesting to see the public comments on how that comes back and what people say about the extra requirements that are going to be involved if you're going to extend beyond use stating. But I mean, I don't have any complaints. I was, totally a nerd and, sat down and I've read them a couple of times already. So,
Well, I'm
as you
sorry
can
to
imagine.
put you on the spot, but that's great. I mean, that is great that you've combed through it. My quick review was very similar. That was the major change, the only big change from the previous proposed revision. But
Yep. I mean, I personally, as far as some of the comments from before when they recalled the chapters based on the Beyond You states, some of the questions were if you were going to extend it, you needed to do more things if you were going to extend your dating, especially for sterile, as far as environmental monitoring and competencies and stuff like that. So from an inspector standpoint, from somebody who's, a self-proclaimed geek about USP stuff, I like the extra stuff that they added. I think it will really help safeguard some things going forward.
thank you for that report. And again, sorry for the surprise, but you handled it well.
No worries.
It's impossible to surprise Crystal on USP matters.
Good.
I texted. Sorry, Wallace. Go ahead.
No, go ahead. No, you
I was
go
going to say
ahead.
that the night they released it, I texted 2 of the USP committee members that I know, and I was like, I'm sitting here nerding out right now. I'm sitting here reading these chapters, and they both laughed and said, "Happy reading, enjoy."
I don't.
Go ahead.
What I was getting ready to say is I was just curious. At some point for the board just to at least have a little bit of a discussion, not or just an awareness or presentation or something. It could be a retreat kind of thing that, like, where these things have changed and sort of a summary deal. And maybe I'm asking for something that's not something that could quickly be done, but I just think for the record, it might not be a bad idea to try to have at least know that has been discussed with the board for what it's worth.
Yeah, absolutely. I could probably put something together for you guys as a summary update of the chapters. And I mean, it may not be perfect, but I can at least put it together to let you guys know what the big major changes were from previous published chapters to the current published revisions. I can put something together for the retreat.
One of the biggest concerns I have is on the non-sterile side, and that's the current 795 has very little about facilities, and the new chapter is pretty prescriptive with regard to facilities and environment, and so much of it was just copied right out of 797. I'm not sure how that's going to get implemented by many compounders.
I agree. That was a concern in the back of my head about what current non-sterile compounder setups are and what the proposed revisions are had, but we'll see what the final revisions are published.
Well,
it could take another couple of years before that actually is finalized. So we'll see.
Most likely, yes.
Yep.
Thank you, Crystal.
Absolutely.
Jay, is Missy ready to present on licensing?
Missy's always ready and prepared. So
okay.
I'm here. Everybody hear me okay?
Yes, thank you.
Alrighty, so I don't have any numbers to present this month because renewal hasn't started, but I did want to just get on the radar and let you know that we are working on some, items for the upcoming renewal. It starts on November 1st on Monday. That is a Monday. And this year we're, going to add a couple of things. I'm always thinking about username and password and security questions. And this year we're going to try to streamline that process for folks that have forgotten what that information is. Our programmers are working on it right now, but likely it'll be in the form of a form for them to enter in their information, and then it'll come over to me, and then I'll be able to assist them that way. I'd like to streamline the process instead of having everybody call in when they have a problem forgetting, logging in because they forgot their username, password, and security questions. We're gonna, on the actual renewal itself, which you will all see as pharmacists, we will add additional checks to verify or update your home address, your phone number, your email address, and where you're working. So you'll be able to verify and or update. Additionally, I'll be making some how-to videos about completing likely the three biggest renewal applications that we have: pharmacist, pharmacy, and pharmacy technician, just to give, applicants the idea of what the renewal looks like. And then this last one is a little far into our process, but I wanted to let you all know that during renewal, oftentimes, if there's a transfer of ownership or re-registration that's submitted, and then that effective date goes into January, we have to allow that pharmacy to renew. So what we've done proactively is added a pop-up box if they're going to complete those applications, and let them know that they need to renew the permit first and then submit the application, so that they don't run into any problems with distributors and things of that nature. So that's about it. I mean, it's a quick update, not too substantive with numbers, but that's what I'm working on right now. If you guys have any questions, let me know.
Thank you, Missy. Doesn't sound like there are any questions for you. Very good.
Thanks, Missy. Next, I'm sorry, Bill.
Go ahead.
Board elections, everybody knows they're coming up for the Western and the Northern districts. The deadline for candidates who wish to stand for election from either of those districts to file their petition and their signatures is October 1st. So we're still a couple of weeks away on that. We do have two candidates who I'm not trying to play cloak and dagger, but as y'all know, we don't say who the candidates are until the deadline is passed, and we announce all that at the same time. But there are two candidates who have completed the petition process to be on the ballot for the Western District. There could be more, of course. We've got another couple weeks left. And it certainly appears, although we haven't quite gotten all the paperwork in yet, but it certainly appears there are going to be two candidates for the Northern District contest as well. Kristen Moore, as you all know, runs the elections, and she's been in contact, as have I, more sporadically, but Kristen has been in contact with folks, and we've had good questions and interest. So it's all moving as it should. After October 1st, when the deadline passes, of course, the next stage will be for the candidates to provide biographical statements and pictures, and we will immediately get the information up and out about the upcoming election. So moving smoothly as Kristen always makes it move.
Very good.
Remaining three things, just meeting stuff. Reminder about District 3 in Monoclonal, the dates of those coming up. Work with Cindy and Leslie if you need any late registration or any assistance with any of that. NABP District 3 is going to go forward in person, take appropriate precautions, as is Monoclonal. And so I don't think we need to replow ground on that. I'll include those in when I send y'all the committee reset in the October calendar. I'll build all this in so we show everything that's going on. And then our board member retreat, as we've already talked about, at the Carolina Inn here in Chapel Hill. And folks can begin arriving on Sunday, November 7th. Monday, November 8th, we will have the required statutory training, which Mr. Pinion will present. And then one of the 2 days, Representative Sasser is going to stop by, so we have an opportunity to chat with him. And then as soon as all the training stuff is done, we will move into the retreat proper. I have collected and am collecting topics for the retreat. I will be providing to all y'all. I'll provide that with sort of the omnibus, what's coming up, sort of information later today, the retreat items that I have, and certainly encourage you if there are additional items or things that are on that list that you don't think need to be on there to let me know about that. Would be super helpful if we could more or less lock in on what our retreat topic is going to be by the end of this month, so that staff's got, in addition to everything else going on in October, we can make sure that we've done any background prep that you guys to facilitate your discussions of those topics. So do let Leslie know. I think Leslie's reached out. Just be sure you let her know whether you are going to stay at the Carolina Inn, which you are certainly invited and encouraged to do. We will be having a dinner on that Monday evening, the 8th. But make sure you work with Leslie on getting your arrangements made for that. Any questions on any of that? All right, Bill, I'm not hearing any.
Nope. What do we need to do for the consent agenda? We didn't have any.
We don't have any. Yeah, we don't have any consent agenda items. So unless there's anything else for open session, we could move into closed session. And we do have two potential summary suspensions to discuss. And of course, you guys have time to discuss the technician ratio request as well. And
I'm sorry, but do we need to approve the consent agenda?
No, because there's nothing to approve.
Okay.
Everybody's in perfect consent on that.
All right. Very good. Well, that concludes our open meeting. We need a motion to adjourn from our open meeting and
if I might just very quickly, Bill, and I apologize for those who are attending, the board is going to move into closed session to discuss some closed session items. When they come back out of closed session, there will be no more agenda items. So when the board moves into closed session, attendees will be logged out at that point. Sorry, Bill.
No, that's perfectly fine. Everybody needs to hear the explanation. Okay, motion to adjourn.
I'll make that motion.
And move to closed. Michelle, second.
No, Michelle didn't second. I'm sorry. Michelle has discussion. Sorry.
Oh, I'm sorry. My apologies. So we have a motion. We don't have a second yet, but we can have discussion now.
Can we also incorporate maybe a 5-minute bio break?
Absolutely.
Certainly.
That was the discussion.
That's the most important discussion.
Especially if you'll second the motion to move into closed session, then we'll take a break.
I'll second the motion.
Okay, we got a motion to approve and second by Andy, third by Michelle. Andy, all in favor?
Aye.
Are you in favor? Keith? Ashley? All right, Wallace? Wallace, you approving moving to closed session?
Yes, I do. I'm having so much breakup on this signal today, or especially now, just the last few minutes, it's gotten really bad. So
yeah, okay. Motion's approved. Thank you all from the public part of the meeting. We will convene the closed session in 5 or 6 minutes.